Hematology. We're going to start hematology now. Hematology is going to, we're going to do today, Friday, and then we'll try to wrap things up on Friday if possible, but it's a lot of material, so we're probably going to leak into next Wednesday. And then next Friday is your exam, right? So whenever I do my exams, I usually stage the exam the last day of the week. So for this class, it would be on that Friday. The exams are going to be 30 questions, multiple choice. So yeah, good stuff. A lot of the stuff is going to be on hematology. Hematology is a pretty significant chunk of this class. So there's a lot to it. We're going to talk about things that affect the red blood cells, white blood cells, etc. So pretty important stuff. Anyways, has anybody here seen that movie? There Will Be Blood? Breaking Bad. No, it's got Daniel Day-Lewis in it. It's a really good movie. He's like an oil prospector. It's awesome. And it came out like 15 years ago. I'm like, no one's seen that movie. It's one of my personal favorites. I Drank Your Milkshake. Have you seen that part? Oh, you should watch the movie. It's pretty funny. There's an epic scene at the end where he's like, I drink your milkshake. I think Daniel Day-Lewis has probably won an Oscar for that. He did also Gangs of New York, which was awesome. Any metalheads in here? Gosh. Yeah? Okay. This is by far their best album. Did you see them when they came into Phoenix? You did? How was it? Dang. Yeah, it got canceled because Mitch Hedfield got COVID or something. Yeah, that's dope. I wish I would have gone. I was too busy. I didn't get a chance to go. But whatever. I had friends that went too. So a little jealous. So these are all the things that we're going to be talking about. So we're going to be talking about red blood cell disorders, especially all the different types of anemia. That's what we're mostly referring to when it comes to red blood cells. We're going to talk about bleeding disorders, so things that affect either the thrombocytes, like platelets, or things that affect the clotting cascade. So maybe like a factor VIII or factor IX deficiencies that can cause hemophilia. We're going to talk a little bit about von Willebrand's disease, etc. So a lot of that we're going to be focusing on Friday. And then hopefully in Friday we can also cover all of the white blood cell disorders. So that maybe we can just like blast through it on Friday, and then we can do a review maybe next Wednesday. That would be kind of my goal, but no promises because there is a lot of material to cover between now and next Wednesday. So white blood cell diseases, that's a whole other litany of stuff. So lots to go into in that regard. So what is blood made of? So a lot of this is going to be a review because all of you took A&P, right? So this is going to be kind of a review on A&P. We're going to go back into the clotting cascade. So all the basics so that we can understand what the pathology is and how those manifest with their different signs and symptoms. So blood is going to be made up of your three formed elements, right? You got platelets, white blood cells, and your red blood cells, right? What's the most abundant thing in your blood? Plasma, great. And what's plasma mostly made up of? Water, great. So other things that are important are going to be your globulins, right? Immunoglobulins for, fighting off infections, as well as albumin, which is important for maintaining oncotic pressure. We talked about that quite a bit already. Other things that are important, so you got platelets, right? Platelets are going to be your thrombocytes. Those are really important for initiating clotting, right? So when you get that platelet plug to block maybe a leaky vessel, that's going to be important. And then you also have all of your clotting factors that come into play afterwards to create that fibrin mesh, right? So you can create a nice little clot to prevent any further bleeding from taking place. So that's all basically going to be in your red blood cells, right? That's going to be things like floating around your plasma, and your red blood cells are going to be the most abundant cells next to your leukocytes. Leukocytes are going to be your least abundant cells, but also super important. And then when you're looking at a patient's chart, doing their complete blood count, their CBC, you're going to look for a couple things. You're going to look for the hematocrit, right? You want to make sure that the patient's not anemic, right? So you just check their hematocrit level, which is just the percentage of red blood cells compared to their plasma, right? And so if they're anemic, their hematocrit is going to be reduced. So that's going to be this value over here. So the standard range, sometimes some texts say 37, but this one over here is going to be 40 to 52. If you're less than 40, then you're going to be anemic. If you have more than 52, that means you have maybe hemochromatosis, which is going to result in way too much red blood cells, which is pretty dangerous. You actually have to do iron chelators, and sometimes you have to do phlebotomy to remove the person's red blood cells so that they don't get things like clots and whatnot. Then you also check for the size and the color of the cells, which is going to be determined by these three values over here. So we're going to go into details about that momentarily. Other things to look at, of course, would be their white blood cell count, right? Depending on what white blood cell is spiking, can tell you a lot about what kind of infectious agent the patient might have. So if they had a neutrophil spike, if their neutrophils were really high, that means that they probably have a bacterial infection. If they have a spike in their lymphocyte count, it maybe could be a viral infection or other things, right? It could be even cancers can cause lymphocytes to spike. Eosinophils, person might have a parasitic infection. Maybe they have like a tapeworm or a liver fluke or something like that. So the CBC tells you a lot about the patient. If they have too many red blood cells, that's called polycythemia. If they have too few red blood cells, that's anemia. So pretty straightforward definitions for you. So what is anemia? Anemia is a couple things. It could be decreased quantity or decreased quality of your hemoglobin. So if you have decreased quantity, maybe, for instance, you have a vitamin deficiency. We're going to talk about the two major types, vitamin B9 and B12. Those can decrease the quality. What could decrease the quantity? Maybe you have, maybe you're bleeding. Maybe you got hit by a bus and now you're bleeding out. That's acute blood loss would decrease the quantity of your hemoglobin. So if you had any sort of impairment in the erythrocyte production, maybe it's a vitamin deficiency as an example, then that could cause anemia. If you have blood loss, whether it's acute, you got hit by a bus, or chronic, maybe you have like bleeding peptic ulcers and you're not aware of it, you could be losing blood that way. You could have bleeding diverticula. You could lose blood that way. Women in reproductive age sometimes run a little bit anemic because you're losing blood through menses, especially if you have very heavy cycles. And then erythrocyte destruction, right? So if you're undergoing hemolysis of some sort and the red blood cells are getting destroyed, that could cause anemia. You could see that, for example, in patients with malaria, right? Malaria is going to be a plasmodium that enters into the red blood cell, and the red blood cells burst. They undergo hemolysis. So those are all different things that can cause anemia. Let's watch a little video. Hopefully it works. Short.
Red blood cells contain bright red protein. When we breathe, our blood passes through our lungs, oxygen then the red blood cells in all our cells. When the hemoglobin molecules are carbon dioxide and other waste, they take back lungs to be. There are too few blood cells, or not enough hemoglobin. Exhaustion is a common sign.
I'm exhausted right now, so I think I'm probably anemic. as I'm sure some of you are too. So anyways, so that's anemia in a nutshell. Pretty straightforward stuff. So you could have a normal red blood cell count, that's normal. If you have reduced red blood cell count, that's anemia. Symptoms can range for anemia. Symptoms can be asymptomatic. The person might not even know they have anemia. Maybe they get a little fatigue, right? They get a little tired. Symptoms can also be very significant and severe, depending on how bad the anemia is. I didn't put it in here, but actually, yeah, you can look. There's another chart that you can see that has like all the, different organ systems that are involved. If anemia is really bad, what does your heart do? It's going to try to compensate for the lack of oxygen delivery. It's going to, beat faster, right? You're going to have tachycardia. If you have very severe anemia, your heart is going to start racing because it's trying to pump and deliver oxygen to your tissues. What about your respiratory rate? What's going to happen to your respiratory rate? Does it go up or down? Become tachypnic, right? You start breathing really fast because you're trying really hard to get as much oxygen as possible in your circulatory system. So you would see things like tachypnea. You might even get dyspnea, which is getting out of breath. You might see lethargy, right? You're feeling really tired because you're not delivering oxygen to those tissues, right? So you might see fainting. You might get syncope as a consequence of severe anemia. This is often what you see on a physical exam, pallor. So you can look at the patient's conjunctiva, and if they have real pale conjunctiva, that's a sign of anemia. You can look at their mucosal membranes, and you can look inside their lip, and if it's really pale, then you could say that the person has anemia. You can also see changes on the patient's tongue as well. You might see smoothing of the tongue. That would be characteristic of anemia as well. Claudications. What is a claudication? What does that mean? The term claudication is referring to hypoxemia of those tissues. You're not getting adequate oxygen delivered to those tissues, and when you get a claudication, it hurts. So it's a very painful cramping, things that you're not getting oxygen delivered to those tissues. So it's very painful. You get buildup of lactic acid and whatnot, so it doesn't feel good. So these are all the major symptoms of anemia that you would see if a patient is symptomatic. But again, oftentimes patients are asymptomatic. They don't even know they're anemic. And then if they have, if their symptoms are not that pronounced, sometimes it only happens on exertion, right? The patient maybe is walking up a flight of stairs, they get out of breath, right? So that could be exhaustion on exertion. So mild symptoms, you might get weakness, fatigue, pallor, right? So here's your conjunctival. So that's a normal conjunctiva. If you see the conjunctiva looking really pale, then that could be an anemic patient. Smoothing of the tongue could also be considered anemia. I still don't understand why the term beefy. It doesn't look beefy to me, but beefy red tongue is kind of like the pathognomonic physical exam sign for vitamin B12 deficiency specifically. Cold, right? You're feeling kind of cold. You're not getting enough blood, red blood cell. Blood helps you thermoregulate, right? Vasoconstriction, vasodilation, that can help to increase or decrease the temperature in those tissues. If you're anemic, you might have cold hands and feet. Nail changes. Not exactly sure why this happens, but you get spooning of the nail, koilonychia. And then hair loss. So apparently iron and blood is important to maintain the integrity of your hair follicles. So if you're anemic, one of the things that you might see is hair loss or alopecia. Alopecia is a fancy term for losing your hair. And if you have severe anemia, then you might have shortness of breath. That just means dyspnea. That's the fancy term for shortness of breath. Chest pain, arrhythmia, tachycardia, of course, we talked about that. And then syncope and orthostatic hypotension, right? So orthostatic hypotension, you're laying down or you're sitting down for a long time. The blood might pool down at your feet if you're sitting, or if you're laying down and you get up too fast, the blood rushes out of your head and down to your feet, and then you can pass out from that. So that would be orthostatic hypotension, and if you pass out, that's called syncope. right? There's a couple different types of syncope, but syncope generally means you lost consciousness. It could be cardiogenic. It could be due to like arrhythmia in the heart. It could be due to, it could be neurogenic. It could be due to maybe something happening at the level of your neurons. But if it has to do with anemia, that's going to be dealing with just oxygen not being properly delivered to your brain and then losing consciousness that way. If you have vitamin B12 deficiency, you're going to see neurological symptoms as well. So you might see gait imbalance. You might see numbness and tingling. So you might see peripheral neuropathy as a consequence. So if you see neuropathy plus all the other signs of anemia, then you'd be thinking vitamin B deficiency. That's unlike vitamin B9 deficiency that doesn't have neurological symptoms to it. So we'll talk about that a little bit later. So what are we looking at on the labs? The three major things besides the hematocrit, because we want to look at the hematocrit, right? You see if the hematocrit's within normal level limits. The other major values are going to be mean corpuscular volume. Okay, so that's the size of the red blood cell. So if the mean corpuscular volume is reduced, they call that microcytic. If it's large, it's macrocytic. So that means it's a large red blood cell. Another term for macrocytic, if you're talking vitamin B9 deficiency, we call that megaloblastic anemia. Pretty awesome word. Sounds like a superhero of some sort. But megaloblastic anemia means that you have a really large red blood cell. It's not a good thing. Those red blood cells tend to get destroyed. They hemolyze more readily. So that would be one thing that you'd be looking at with the size. You could also look for the mean corpuscular hemoglobin levels. That's the MCH, how much hemoglobin is in that cell. Not super pertinent to the labs that we're looking at for the sake of this course, but the most important other lab is going to be the MCHC. So that's the mean corpuscular hemoglobin concentration. And what that determines is if the color of the cell is fainter or normal or a little bit more dense in terms of its color. So if it's if it has a lighter color to it and you can see through it more, it's called hypochromic. If it looks normal, that's normochromic, and if it's really like dense in color, that's hyperchromic. So different types of anemia will look different in terms of the color of the red blood cell when you look at it. So in terms of size, so macrocytic, it's large, normocytic, normal, microcytic, it's small. Hyperchromic versus hypochromic versus normochromic, right? So hyperchromic, very dark. Normochromic, you see that little tiny donut in the middle, right? So it's got a little bit of a clearing in the middle. Hypochromic, you're very faint in terms of its coloration. And then these can be combined. So you can get a microcytic hyperchromic anemia. That's going to be something you see in iron deficiency anemia. If you don't have enough iron, you're going to have smaller red blood cells, and the red blood cells that you do have are going to be very clear, so you can see right through them. So microcytic, hypochromic. Macrocytic, normochromic is something that you'll see in vitamin B12 deficiency, as an example. So if you have like pernicious anemia, which involves vitamin B12, your erythrocytes are going to be large. But the color is going to be the same because the MCHC is going to be within normal limits for those megaloblastic anemias. So we'll talk about that in more detail later on. So this is an example of what peripheral blood smear would look like. This would be a macrocytic normochromic. So this patient over here on the right might have maybe like pernicious anemia, vitamin B12 deficiency. So their erythrocytes are large, but the color is actually normal because the MCHC levels are within normal limits. This, on the other hand, on the left, microcytic, so they're small, hypochromic. So this person probably has maybe like iron deficiency anemia. So that would be, first of all, it's the most common kind of anemia. Secondly, these are the type of values you would see, right? So iron deficiency anemia, very common, and this is what you would see on a peripheral blood smear. So let's do a practice problem. So let's look at the values. First of all, let's see where the hematocrit is. So the hematocrit is over here. Is that low? Yeah, so the patient's anemic, right? So the hematocrit's a little bit lower. So it should be around 0.37. For this person, it's 0.33. What about the next value? So you got the MCV, so that's a mean corpuscular volume, right? What's the MCV look like? Is it low or is it high? It's low, right? So what does that mean? It's a microcytic, normocytic, macrocytic. Microcytic. So this person has a microcytic anemia. We know that. What about the other value? Mean corpuscular hemoglobin, not super important for this type of like diagnosis or the labeling. So we look at the mean corpuscular hemoglobin concentration. Is that low? Yeah, it's low. So what's going to be the color of the red blood cell? It's going to be a little bit fainter, right? So this is going to be microcytic, hypochromic anemia. What does the person probably have? Huh? Yeah, they probably have an iron deficiency anemia. So, different types of causes. So to recap of some of the things we talked about already, losing your blood, right? If you are hemorrhaging, it could be acute, right? You could have an acute hemorrhage. Maybe you got into a motorcycle accident, like one of my students. He had a pelvic fracture, 30% survival. This kid actually survived. So he's like, he's got a really good guardian angel out there looking after him. But if you were to get a pelvic fracture that ruptures through the femoral artery and femoral vein, you're bleeding out really fast. Those individuals die, it's like about 1 minute, 2 minutes. You bleed out very rapidly. So acute blood loss could cause anemia. Chronic blood loss, of course, can also cause anemia, right? So there's anemia of, chronic blood loss due to, like I mentioned earlier, peptic ulcer disease can cause that. Bleeding diverticula can cause that. If you don't have the ability to produce your red blood cells properly because you're lacking certain vitamins, you can also get anemia. So iron deficiency anemia, we just talked about that. Microcytic, hypochromic. But you can also have B9 and B12 deficiencies. Those would be megaloblastic type anemias. Those would be macrocytic, and they would be normochromic. It would have normal color. But that would result in poorly produced red blood cells. They're going to be big, but they're also going to be kind of like sloppy. They're going to fall apart. They're going to hemolyze more readily. So you ultimately lose those red blood cells, causing anemia. And then you also can see hemolytic anemias. You can see that in things like beta thalassemia, sickle cell disease. Sickle cell disease we're going to talk about as well in this class because it's interesting. Sickle cell, I think, is one of the most interesting types of anemias out there for many reasons. Has anybody seen this movie? You have? Some of you? Okay, good. All right. Huh? Monty Python. Yes, it's merely a flesh wound. It's a great scene. Anyways, the carrier pigeon scene, I think, is one of the funniest ones. It's talking about different types of carrier pigeons. So, bleeding, of course. So, trauma, right? Peptic ulcer disease, bleeding GI tract, right? You might have bleeding diverticula. Hemorrhoids can cause this too, if it's severe enough. Usually hemorrhoids don't really bleed that much, but you can get, I guess, pretty bad cases of hemorrhoids. So the hematocrit is going to be reduced, right? Because remember, your hematocrit, it's nothing more than just a ratio. It's a percentage, right? If you reduce the amount of red blood cells, you're going to reduce the percentage of red blood cells. So it's going to cause a reduction in your hematocrit. If you have blood loss, this is what it looks like. The cells look normal, right? The cells are going to look normal because you're producing the cells normally. You're just losing them because of a bleed. So they're going to be normocytic, so they can be normal size, and they're going to be normochromic, normal color, no difference whatsoever. The hemoglobin level is going to be reduced, though. Hematocrits can be reduced, but you have normal size and you have normal color. By the way, what's the hormone? Erythropoietin. Good. Yeah. So the hormone erythropoietin in your kidneys is going to be responsible for the production of red blood cells at the red bone marrow, in your long bones especially. Aplastic anemia. When you see that term aplastic, it means that things are not being produced. right? So it is an anemia due to the fact that you're not producing the actual red blood cells. And so if you have a really severe type of aplastic anemia, like total just bone marrow failure, that's called pancytopenia, right? Pan meaning all the cells, and then cytopenia meaning that you don't have enough of them. So you're not just going to get a reduction in red blood cells. You're also going to get a reduction in white blood cells, and you're also going to get a reduction in your thrombocytes or your platelets. So you get thrombocytopenia, leukopenia, and anemia from your red blood cells. So things that can cause this, right? If you have radiation exposure, toxins, you can also have autoimmune diseases causing this. All sorts of viruses can cause aplastic anemia. And then different drugs. That's the scary thing, is that sometimes you can take certain drugs, like, for example, chloramphenicol, that's an antibiotic. Carbamazepine, that's an anti-epileptic drug. Phenytoin, epileptic. Quinine drugs. What are quinine drugs used for? Do you guys know? Well, hydroxychloroquine, chloroquine. Any of those quinine drugs are used generally for like malaria. You can use them for other things too, but they're generally going to be anti-malarial drugs. So they can cause aplastic anemia at the level of the bone marrow. Chronic blood loss. So if you're losing blood over a long period of time, that's going to cause iron deficiency. It's going to be seen especially in older people with GI bleeds. They might just have chronic GI bleeds. Maybe they have peptic ulcer disease. Maybe they have bleeding diverticula. So that's pretty commonly seen. And for women, menorrhagia. Menorrhagia is just heavy menses. So those are the most common types. These are going to be microcytic hypochromic, right? So it's going to be it's going to be basically like iron deficiency anemia. Right, so small cells, and they're going to be clear in their appearance. So this is what normal cells look like, normocytic, normochromic, and this is what microcytic would look like especially this guy over here is pretty tiny. This one looks all kind of weird, teardrop shaped. Sometimes you see like teardrop shaped red blood cells, but the color in general is going to be a little bit fainter. Like this one over here is especially faint. All right, so iron deficiency anemia, as I mentioned, this is the most common type of anemia. You're not getting enough, maybe you're not getting enough iron in your diet, might be one reason. For women, it could be due to just menses, right? You might just be losing a lot of your blood. Chronic GI bleeds can cause this as well. But the major thing is going to be inadequate iron intake, or you could see poor absorption. So if a person has celiac disease, right, it's going to cause all sorts of irritation in their GI tract. They're not going to be able to absorb nutrients. People with celiac disease generally can lose weight because they're not absorbing the nutrients. I don't know if I mentioned that in this class. A neighbor of mine, she had celiac disease. She would purposely eat gluten so she would lose weight because you'd be losing all the nutrients, right? You're just like crapping it all out. And so she would do that deliberately to stay skinny. And she was like rail thin. So yeah, malabsorption. So celiac disease can cause it. Chronic diarrhea. You can get diarrhea from celiac, but you can get it from other things. If you don't have enough hydrochloric acid being produced, you can also get poor absorption of those nutrients. Yeah, so lots of different things can cause it, right? Menstruation, pregnancy. We'll talk about that in a second with pica. And then, of course, chronic blood loss, right? So ulcers, secondary to NSAIDs, right? NSAIDs are going to be one of the most common causes of ulcers. What else is a really common cause of ulcers? Huh? Stress. What else? H. pylori, you guys know that one? Helicobacter pylori is one of the most common causes of ulcers. You can treat that easily, right? You do the urea breath test, you test positive, then you give them antibiotics. You can just treat it that way. So you can get ulcers causing anemia. PUD, that's another term for peptic ulcer disease, right? So menorrhagia, heavy menses, esophageal varices. Why do people get esophageal varices? Huh? Yeah, so liver cirrhosis and alcoholism. Cirrhosis you'll get in the portal venous system because the the liver's so damaged, blood is going to find other alternate routes. Some of those are going to be within the esophagus. So you get these large varicose veins in the esophagus. You can also get veins that are throughout the abdomen. We call it caput medusa. So if you get bleeding esophageal varices, that can cause anemia, obviously, because it's bleed. UC is ulcerative colitis, Crohn's disease. Any of those things can cause anemia. What does iron deficiency anemia look like? So the red blood cells, they're going to be microcytic hyperchromic, right? So the mean corpuscular volume is reduced. The MCHV is reduced. Other things that you could see on physical exam. Well, generally, you're going to see things like fatigue, tachycardia, etc. Pallor, obviously, is going to be a big thing, but koilonychia, right? So koilonychia is where you have the spooning of your nails. Don't ask me why it happens, it just happens. So you get these weird little curvatures in your nails. You also can get angular cheilitis or colitis, where you have basically kind of like abrasions at the corners of your mouth. So that's called angular cheilitis. Alopecia, hair loss, right? So you can see a little bit of balding in that. The tongue, smooth, right? So this is after treatment. Before treatment, you see smoothing of the tongue. Pica is really interesting. You see pica, especially with like pregnant women, and a lot of it's like psychogenic, it's like psychological. But for anemia, people might start getting cravings for dirt, right? So oftentimes a person who's anemic all of a sudden wants to eat dirt. Like literally, they'll eat dirt because you find a lot of iron in soil, right? You find iron in dirt. And so pica is psychologically mediated, right? So it's psychogenic in nature, and it's where you're basically eating things that are not of general nutritional value. It's not just dirt. It can be other things too. People can get pica in all sorts of ways, but the most common one is going to be wanting to eat dirt. So kind of interesting. So this is what we would look for in a CBC. Everything is going to be reduced, right? Your reduced red blood cell count, reduced hemoglobin levels, reduced hematocrit, reduction in your corpuscular volume, reduction in the corpuscular hemoglobin, as well as the concentration of all that hemoglobin. So everything basically is going to be lowered when you have iron deficiency anemia or just chronic bleeds, right? All right, so erythropoiesis, let's kind of briefly go over it because it kind of has an implication in why red blood cells get all big, right, in a megaloblastic type anemia. So this is how a red blood cell is produced, right? So you have your myeloid progenitor cells that eventually turn into your hemocyte, blast, et cetera, et cetera. Then you get your early erythrocytes. Eventually, the nucleus is expelled. Why is the nucleus expelled, by the way? Why do you not want a nucleus in your red blood cell? I'm not testing on it, but it's kind of interesting. What? Mm-mm. It's a very simple answer. What's the most important thing in a red blood cell? Huh? Yeah, hemoglobin, exactly. So hemoglobin is the most important thing. If you want to maximize the amount of hemoglobin, you eliminate the red blood, the nucleus. Other animals have nucleated red blood cells. So amphibians, so frogs, salamanders, birds have nucleated red blood cells. The thing is about like salamanders, frogs, they have a lower metabolic rate, so they're not metabolizing as rapidly. And especially with like frogs and salamanders, they can actually kind of respirate through their skin, so they can actually do breathing through their skin. But the good thing about having a nucleated red blood cell is that you can undergo mitosis, so you can create more red blood cells. For us, we have a higher metabolic rate, so we're constantly undergoing like metabolism, and so we need a lot of oxygen. So to maximize oxygen delivery, we remove the nucleus. But because of that, the red blood cell has a finite lifespan. How long does a red blood cell last? On average, it's about 120 days. That's about the average lifespan of a red blood cell. Once it's gone, that's it. It's sequestered either in your spleen. That's one of the most common places. You can also get sequestering in your liver, right? So those red blood cells get broken down. The hemoglobin gets broken down into its constituent parts, the heme as well as the iron, and then those things can be recycled. But in the production of the red blood cell, it's going to undergo all these different changes until eventually it's this nice little tiny biconcave erythrocyte. Now, if you're not able to produce your erythrocyte properly, because you might have a vitamin deficiency, either vitamin B12 or vitamin B9, your red blood cell is going to stay larger, right? So it's not going to undergo complete development. It's not going to properly develop, and so it's going to become macrocytic. That's why you get macrocytic anemia or megaloblastic anemia with those types of deficiencies. So megaloblastic anemia, that's when you have a macrocytic normochromic anemia. The person's going to have a very large mean corpuscular volume, so it's going to be larger in size, but their mean corpuscular hemoglobin concentration is going to be normal. So it's going to look, in terms of color, it's going to be normal. So that's that. And then those cells, if they're not properly produced and they're too large, they eventually start breaking down. And so you start getting destruction of those red blood cells. And when you get destruction of the red blood cells, that's when you get the anemia taking place. Okay. B9 and B12, here are some interesting biochemistry cascades that you see taking place with the presence of vitamin B12 as well as vitamin B9. So folate, that's vitamin B9. If you have too little vitamin B12, what might you see becoming elevated as a consequence? You're looking at that cascade. You can blurt it out if you want. Yeah, but of these things in this cascade. So here's your vitamin B12. If you don't have vitamin B12, what's going to start accumulating? Yeah, exactly. So homocysteine is not going to be able to turn into methionine properly. So you're going to get an accumulation of homocysteine backed up. It gets built up. So that you can actually test for vitamin B12 deficiency by checking their homocysteine levels. What else might you see in a vitamin B9 deficiency? If vitamin B9 is low, what else might you see go up? No. No. Well, folate is vitamin B9. So if you don't have folate and you don't have vitamin B9, what's going to accumulate? Exactly. It's the same exact thing. So you'll see a rise in homocysteine levels. So you'll see a rise in homocysteine levels in both of these because they're both necessary to be able to create methionine. Yeah. Good. All right. So with vitamin B9 deficiency, you're basically not able to produce your red blood cells properly, so it affects the DNA production. It prevents homocysteine getting converted into methionine. Now, vitamin B12, this is where it gets different, right? This is how you can differentiate between the two. Neurological involvement. Because with vitamin B12, it's also important to produce myelin. And we all know what myelin is important for, right? What's it for? It's like insulation, right? It's like insulation around a wire, so it helps maintain the integrity of the conduction, the action potential. So if you have demyelination, such as the case with patients with like multiple sclerosis, right? If you have demyelination, then that signal slowly dissipates, and you don't get a proper action potential. So same thing with demyelination with vitamin B12 deficiency, you're going to get all sorts of neurological side effects. You might get unsteady gait, the person might be off balance. Other things you might see, peripheral neuropathy, numbness and tingling in their hands and feet, right? So those are things you would see with vitamin B12 deficiency. Vitamin B12 deficiency, side note, you can see vitamin B12 deficiency in pernicious anemia, right? If you're not producing intrinsic factor, so you're not able to absorb the vitamin B12 from the diet. What else might you see vitamin B12 deficiency? What kind of people don't get enough vitamin B12? Vegans, yes, vegans. You can get vitamin B12 on a vegan diet, but guess what? A lot of vegans suck at being vegans. So they don't really do a proper diet. They don't take supplements like they should. I knew a lot of vegans. I was a vegan for like a month, and I hated it because I like cheese and I love steak. So but if you are a vegan, you should take vitamin supplements. Right? You want to be able to supplement your diet. Um, yeah. So a lot of vegans also are pastatarians. Like all they eat is freaking carbs all day long. So you'll find it in meats. You'll find it basically like animal products. I think it's in dairy too. But I know for sure it's in, yeah, it's definitely in animal products, like in terms of meats and stuff. Check to see if it's in dairy. I think it's in dairy, but it might not be. I don't know. So, vitamin B12 deficiency, pernicious anemia, that's going to be one cause, right? And that's going to be associated with intrinsic factor. The term pernicious translates to fatal. So if you don't have enough vitamin B12, that could potentially kill you. Impaired absorption, of course, we just talked about, celiac disease. What's IBD stand for? Irritable bowel disease, right? So just chronic diarrhea, basically. Metformin can also cause this. It might be a side effect of taking metformin for diabetes type 2. Pernicious anemia, it could be caused by the stomach, right? That's where intrinsic factor is going to be produced. So if your intrinsic factor is not being produced by your parietal cells, that could be one type of pernicious anemia. It can also be due to a person who has surgery. So if you get removal of the stomach tissues, right, that could also cause pernicious anemia as well. So, in terms of vitamin B9 deficiency, that's also something you can get from diet, right? So, and for B9 or folate, you get a lot of folate from your beans, lentils, things like that. So, beans are good for you. Also leafy greens, so spinach, kale, all that stuff. If you don't, if you have deficiency, that could also be due to alcoholism or pregnancy. So let's talk a little bit about vitamin B12. So with vitamin B12, the major pathognomonic things to look out for on a clinical vignette would be that smooth, beefy red tongue. Does it look beefy and red to me? Not really, but that's what you see on the clinical vignette, I guess. But this is the key thing right here. Central nervous system. So paresthesia, right? Peripheral neuropathy, numbness and tingling, gait imbalance, unsteady gait when they're trying to walk. You might also see AMS, altered mental status, which could be any of those things, right? It could be a person undergoing psychosis, difficulty retrieving memories, just depression, personality changes. Those are all lumped into altered mental status. Diagnostics, you can look for your CBC, right? So what would you see on a CBC for this type of patient? What would their MCV be? Up or down? Up. Good. MCV is up, so they're megaloblastic. Megaloblastic, but macrocytic. And then what about their MCHC? Huh? Normal, yeah. So their MCHC is going to be normal. So it's going to be normal chromic megaloblastic anemia. So you can check their vitamin B12 levels. You could check for intrinsic factor. Homocysteine levels, right? So they'll get an elevation in homocysteine levels as a consequence. They're not producing methionine properly. And then treatment, supplementation. You just give them B12. Side note about vitamin B12 deficiency, it is really hard to become deficient in vitamin B12. I forget how long your liver stores it for, but it's stored in your liver for a very long time. So like a vegan, for instance, you have to be like a vegan for many years on a crappy diet to actually become vitamin B12 deficient. It's very difficult to get there. Generally speaking, I think pernicious anemia, things like that would be a little bit more realistic as the underlying cause. But side note, that was a side note. Let's talk about folate now. So folate is a little bit different. These are the major differences. That's why I highlighted in red and made it all big. So you're not going to see neurological effects because it's not affecting the myelin. Myelin is only being affected by vitamin B12 deficiency. And for whatever reason, you're not getting that beefy red tongue. It is still, however, megaloblastic. So you're going to get enlargement of the cell. So the MCV is going to be high and the MCHC is going to be normal. So make sure you eat your beans, lentils, asparagus, etc. And if you're planning on having a child and you're a woman, then also take your prenatal vitamins because folate is extremely important for neural tube development. If you don't have enough folate, you might get all sorts of complications with the neural tube, some of which are very severe and serious. You can do a CBC, again, similar thing. You would see elevated MCV and you would see normal MCHC. You can check for folate and you can, again, check for homocysteine levels. And again, treatment is just supplementation, just dietary. So this is what happens when you get neural tube defects. There's different types of neural tube defects, but spinal bifida is going to be one of the most common ones. So different types of spinal bifida. There's ones that aren't as severe, so this would be the least of the severe ones. All you see is this weird little hairy tuft at the bottom of their spine in the lumbar region. Don't ask me why the hair grows in spinal bifida. I actually don't know the answer to that. But then there's more severe types where you can actually have sections of the spinal cord actually getting into the outpouching. So there's different degradations or gradations of neural tube defects. So ladies, please take your folate prenatals before you plan on having a kid. Or just have a good diet. That can also help too. So with CBCs, with a macrocytic / megaloblastic anemia, RBCs are going to be low, right? Because you're losing those red blood cells. They're poorly made and they're going to be hemolyzed at some point. So they're going to be destroyed. Hemoglobin is also going to be low. Hematocrit, because of the hemolysis, is also going to be low. Then your MCV is going to be high, right? So you're going to have a larger red blood cell. And then your mean corpuscular hemoglobin concentration is going to be normal. All right, so let's do this chart real quick. So let's go ahead and like pair together and go over it all. Meet it up with your best friend and try to see if you can answer all these, and then we'll go through the answers. I'll give you 3 minutes to answer all of these. All right, so let's go ahead and get through it. What's going to happen to the MCV and the MCHC in acute blood loss? Yeah, they're both going to be normal, right? Because you're producing your red blood cells normal, right? The only thing that's happening is that you had an injury. So you're going to get normocytic, normochromic. That's going to be the terms for that. What about with iron deficiency, which is similar to chronic blood loss? What are those values going to look like? MCV and MCHC? They're going to be decreased, right? And so that's going to be termed what? Microcytic Hypochromic, good. What about with B9 deficiency? The MCV is what? What's the size of the cell? Big, right. What about the color? Normal. So that's called what? Macrocytic, normochromic. You can also refer to that as megaloblastic, right? That would be synonymous. And then what about B12? Huh? Same thing, exactly, right? So it's going to be big cell, normal color. And again, that's macrocytic, normochromic. Any questions? Yes. Yeah. Oh, sorry. Yeah. Feel free to take a picture of that if you want. Any questions? MCHC because you're not producing hemoglobin properly, right? You're not producing enough hemoglobin, so all the values are going to be down, right? The size of the cells are going to be small. The amount of hemoglobin is going to be lowered, right? So you get that with iron deficiency and with chronic blood loss too. Any other questions on all that before we go on? Anyone seen this movie? That's a great movie. If you guys haven't seen it, definitely watch it. It's one of the best Dracula movies out there. Gary Oldman did a good job at that. It's also got Keanu Reeves when he was back in his younger days. So, and what's the lady from Beetlejuice? I forget her name. Anyways. All right, so let's do a couple questions and then we'll continue on. Huh? Hold on a second. No. Wait. Sorry, I was editing the questions before we started today. Okay, there we go. All right. So go ahead and sign in and then we'll go through these questions. I'll give you a second. All right, so for the interest of time, let's go ahead and start. You can still log in even after I start it, so. All right, good. Most of you guys got that correct. Lost connection. Sorry. Technical difficulty there. There we go. All right, good job, guys. Is it working on your end? Is it actually working on your end? Well, that is so weird. The internet is bad. That is not good. In fact, that's bad. Let me try to. Oh, there we go. That was strange. All right, cool. So microcytic hypochromic, and both of these are actually correct. So yeah, I'll fix that for you guys. So both of you guys are right, except for you guys in the middle here. So let me actually screenshot that so I know to change it. Okay, screenshot. All right, cool. Next. All right, cool. Yeah. So when you think pernicious anemia, what is that involving? What's that one thing that you need? Yeah, intrinsic factor, right? So pernicious anemia is associated with intrinsic factor. Maybe the cells aren't producing it in the stomach, or maybe you had gastric bypass surgery, so you can't produce intrinsic factor. So good. All right, super straightforward, super easy. What would be the big difference between B9 and B12? So yeah, neurological and the beefy red tongue, right? So that's going to be the major difference. Okay, so let's look at the vignette and see the things that stick out to us. So, chief complaint, fatigue and weakness. How long has it been going on for? 6 months. She gets easily tired. She has what's shortness of breath, dyspnea. She gets palpitations. She has not had syncope, no weight loss. She's been taking iron supplements for the past 2 months without any improvement. Reveals pale conjunctiva mucosal membranes, no jaundice, koilonychia, and angular cheilitis are going to be the major things here. So this is iron deficiency anemia. I know that in the vignette it talks about how she was taking iron supplements, but it hasn't been helping. So that would throw things off. But she doesn't have anything that would indicate these other types of anemias, right? She doesn't have any sort of like neurological sensation changes, right? It doesn't talk about a beefy red tongue. For vitamin B9 deficiency, I guess maybe it could be associated with that, but it doesn't really talk about her like diet issues. And definitely not acute blood loss because it's been happening over the course of 6 months. So a little bit of a stumper, but it doesn't have any of the things that would indicate vitamin B12 deficiency. So that's why it would be iron deficiency anemia. Good? Right. Cool. Yeah, pretty straightforward. So iron deficiency, microcytic, hypochromic. So good stuff. I hope all of you guys get this correct. Yeah, pretty straightforward. Definitely not B9 deficiency because he's talking about neurological changes, right? He's getting tingling, numbness of his hands and feet. So obviously a vitamin B12 deficiency. All right, good. And that's also referred to as what? Megaloblastic anemia. So that's macrocytic, normochromic. Let's do two more and then we'll continue on. What happened to this question? Huh? There was an error with God, what the heck, man? That sucks. Well, most of you guys got it correct, at least on this one. So yeah, vitamin B12 deficiency, megaloblastic, and then homocysteine levels would be elevated, right? Because you're not able to produce methionine properly. Hopefully this one will work on your end. You're all out of it? Oh man. All right, give me the answer then. What's the most common type? Iron deficiency anemia. Awesome possum. Let's finish this. Okay. That's so annoying. All right. So hopefully is it the Wi-Fi in general that's not working? Man, it's so annoying. Okay. Well, all right, let's carry on then. Um, I wonder if the Wi-Fi will work on this. I want to play this video because it's kind of cool to see the connection between sickle cell anemia and malaria. So this is the shortened version. The video is pretty long, but it's really cool. When he examined the blood of about 5,000 individuals, massive study, correlation was really clear. So clear, in fact, that we could really draw a map of East Africa and shade in the areas of high sickle cell, and they were superimposed right on top of the areas of high. Many samples and detailed maps made it clear there was a connection to understand
how sickle cell might protect people from malaria, required thinking about the genetics of sickle cell. Just take a little finger prick or a little heel prick, a little sample of blood.
So if you want to watch the full video, here's the link for that. So super cool. Sickle cell is not super common in our neck of the woods, but where I went to med school, it was very common. The island that I went to med school, Dominica, it's like 90% Afro-Caribbean. A lot of those folks originally came from East Africa, West Africa, right? And so those individuals have a higher rate of sickle cell disease. Why? Because they come from areas of the world that have a higher rate of malaria. And so in those malaria endemic regions, you'll see higher rates of sickle cell because if you are heterozygote for the sickle cell trait, then that confers immunity against malaria. However, if you're homozygous recessive for the malaria allele, then now you have sickle cell disease. And sickle cell disease really sucks. And so when I was in Dominica and we were doing like clinicals and stuff, I saw lots and lots of patients coming in with sickle cell crisis. They call it the sickling crisis. Oftentimes that can happen when somebody's dehydrated, right? Because look what's happening to the red blood cell. It's like shrinking up, right? So if you don't have enough water in your if you're dehydrated, you're not going to be able to have a properly formed cell. Other things that can happen: exertion and exercise that might induce hypoxemia, right? If you don't have enough oxygen, this can also happen too. I was just delivering a similar lecture in my 202 class. One of my students came up and told me that she looks after a little kid who has sickle cell disease. And he's a little kid, so he likes to run around a lot, right? Little kids are always wanting to have fun and run around. Unfortunately, because of running around, it reduces the oxygen levels in his blood, and then he starts developing sickling crisis, which sucks for a little kid because, little kids want to play, but this kid unfortunately has the disease. And so the big thing about sickling crisis is that it really hurts because the sickle cells get lodged into capillaries, get lodged into other areas where they're not supposed to be, right? And then it causes hypoxia, and it causes claudications. You guys know what that term means, claudication? The term claudication means you're not getting blood to that area, right? So you're going to, by consequence, have hypoxemia in that area. And so claudications are extremely painful. And generally for sickle cell patients, happens in the knees, the joints, especially like cartilaginous areas that don't really have great circulation to begin with. So, well, am I with the chest pain? I mean, the chest pain is a little bit different when they don't really call it a claudication, but effectively it's the same thing, right? It's technically the same thing, but we would just call that like, chest pain, pectoral angina, and all that stuff. Claudications, we're mostly talking about like limbs, right? So if you get reduced blood to a limb, that would be a claudication. So, big question. In terms of what you would see, you would with the MCV and the MCHV. The MCHV is actually going to look like it's a little bit higher in concentration. So that's going to be considered a hyperchromic anemia. And because of the cell size, it's going to be smaller. So it's microcytic. So it's a microcytic hyperchromic anemia. And you'll also see things like spherocytes where they look like balls, right? So it doesn't have that proper biconcave shape like a typical erythrocyte would have. And so these are the things that happen when you have sickling, right? The sickling happens, those sickle cells start to undergo agglutination. Agglutination is just a fancy word for clumping up, right? So they agglutinate and then they get trapped and lodged into capillary beds as an example, and that's not fun. If you have the trait and you're heterozygous, you're just the carrier, but the disease, you have to be homozygous recessive for the sickle cell allele. So what happens? You get pain. It's very, very, very painful. These patients that we would have that had sickling crisis, they would be in so much pain. Like you would have to give them analgesics, right, to help reduce the pain. Bless you. So not fun, and especially in, like I said, the joints. You get like arthritis due to the hypoxemia. If it's severe enough and it causes some severe occlusions to those vessels, you can get stroke, right? So you can get some pretty serious side effects from the sickle cell. What's up? That's a good question. Um, yeah, it wouldn't affect the shape of the cell. So if you were taking like aspirin or something like that, it wouldn't affect the shape. The shape would still sickle and it would still get trapped. So the best way to treat it, antibiotics if you like actually get an infection because of the occlusions, but stimulating fetal hemoglobin, because remember fetal hemoglobin, instead of a beta and an alpha chain, it has an alpha chain and a gamma and two gamma chains. So two alpha, two gammas, and fetal hemoglobin has a very high affinity for oxygen. And so if you stimulate the production of fetal hemoglobin, then you can get more oxygen on that cell, and the cell can maintain its shape and its integrity. So hyperbaric chamber can also be a thing, but then the best thing to do would be bone marrow transplant. But yeah, that was a great question. It kind of stumped me for a second. But I guess blood thinners like aspirin, things like that, it wouldn't change the ultimate shape of the cell. So the cell would still get lodged and trapped into those capillary beds. But that was an awesome question, though. Sickle cell anemia in more detail. So you'll see on peripheral blood smear those funky looking shapes. Another thing you might see too is a Howell Jolly body. Howell Jolly body, if I remember correctly, is a remnant of the nucleus. Don't quote me on that, but I think that's what it comes from. It's because you'll get more immature red blood cells being produced. And if I remember correctly, that's where it's from. Actually, let me just let me fact check myself real quick here. My internet doesn't work. Awesome. So I can't even fact check myself. But maybe I'll look into that later and let you guys know. Or if any of your phones work, maybe you can let me know if that's okay. Cool. Yeah. So like it is going to be remnants from the nucleus, basically. Because remember, the nucleus gets ejected from the cell as being produced. But if you're trying to develop more and more red blood cells rapidly, you're going to get more immature red blood cells being produced. So the Howell Jolly body is going to be a leftover of that. So moving on. Keep this in mind. Microcytic, hyperchromic, and then you'll see spherocytes as well. Okay, so those are the things you'll see on the MCV and the MCHC. And then in terms of genetics, you have to be homozygous recessive to actually have sickle cell disease. So if you had both parents, if both parents were heterozygotes, right, then it would follow the rule of 1 to 2 to 1, right? One individual would be homozygous dominant, two individuals would be heterozygous, and then one individual would be homozygous recessive. And that individual would be the one with sickle cell disease. And this is actually a photograph from a peripheral blood smear on my one and only patient that had malaria. So that was kind of cool. I was working in DC, and this dude is from Africa, and he was visiting his family in Africa. And when he was coming back to the States, on the plane, on the flight back, he started to develop fever. He started to get diaphoretic, so he was sweating. He started to get myalgia, so muscle pains. And then eventually he developed jaundice. So he came to the hospital, and we saw him. He had sclera icterus, which is yellowing of the whites of the eyes. And the hematologists were looking at the peripheral blood smear, and they were like, "Come over here and check this out," because it's really rare to see it in the States. And so this is the first and only time I actually saw it. So I took the picture through the microscope, and so those are the little tiny signet rings, right? So that's going to be during the development of the trophozoite within the red blood cell. You're going to see this little vacuole, so it pushes all the contents of the plasmodium to the peripheries. So it kind of looks like a ring shape on peripheral blood smear. So kind of cool. All right. Any questions so far? All right, let's keep on going. It's 12:16, so we got 30 more minutes left, which is good. Got still a lot more to cover. So let's talk about hemostasis. And a lot of this is going to be a refresher from the nightmare of, I guess for you guys, it's AP 211, right? So this will be a refresher from 211 during your blood lecture. So hemostasis, that's the ability to control bleeding, right? That's the fancy term for trying to prevent bleeding. If you have a small microvascular damage, nothing really too crazy, that's easily fixed. You get platelets forming a platelet plug, and then you could get your clotting factors coming in to create a fibrin mesh. But if you have a really big bleed, for those of you who work as EMTs in here, you probably know that one of the big things you have to do if you have a gaping flesh wound is give pressure, put pressure on that wound so you can help prevent further bleeding. This is not someone I knew directly, but one of my colleagues in med school, he was in the military, and while they were in combat, one of his comrades got shot right in the neck, and it pierced his carotid artery. And so to prevent the carotid artery from bleeding out, because of course it's the main vessel providing blood to the brain, he literally stuck his finger in the carotid artery. I guess it would be this way, so it would stop gushing blood. So the carotid artery, you can put your finger in there if you have to. So that's what he did. He put his finger in there so he would stop bleeding out. So yeah, pretty badass actually. Sutures, you can also do sutures too to, of course, stop the bleed. Cool. We just talked about that. Hemostasis, so vasospasms, platelet plugs, and then the coagulation cascade. These are like the three major things that happen. The moment that a blood vessel gets cut, it's going to start constricting. So you get vasospasms. That's an automatic reaction to help prevent blood loss at that local level. Then you're going to get the platelet plug coming in. That's going to be the next step, right? So you're going to have platelets coming in, and they're going to be attracted by von Willebrand factor. Von Willebrand factor is going to be something you find not only in the exposed endothelium, but it's also going to be seen in other platelets too. So von Willebrand factor attracts the platelet to the site of the wound. Then von Willebrand factor from the platelet is going to attract more platelets to that area. So that's when you start developing that platelet plug. And then the clotting cascade is also going to come into play. And there's two major pathways that eventually turn into the common pathway. But you have the extrinsic. That's going to be, generally speaking, due to exposure of the vessel after having like an injury, for example. And so that's going to involve a different pathway than the intrinsic pathway. The intrinsic pathway, all the clotting factors are already kind of in the blood as it is. And so all you need is exposure to collagen, and that kicks off the intrinsic pathway. The extrinsic pathway, you need exposure to tissue factor, which is factor number 3. We'll talk about later. And when you get tissue factor exposed, that's usually due to like a cut, something that exposes the endothelium to factor 7, and that initiates the clotting cascade. And then when you get to factor 10, that's when both of those cascades converge, and now you have the common pathway. And then after you get factor 10 getting activated, then you can get prothrombin turning into converting fibrinogen into fibrin, so you get the fibrin mesh. And the fibrin mesh is effectively how you get that actual clot taking place. So you can congeal all the red blood cells just like this. This is a bunch of red blood cells surrounded by a fibrin mesh. So there's 3 major phases, right? The vascular phase, you rupture that red blood, the blood vessel, and now you get vasospasms, right, to prevent bleeding. Second phase would be platelets, right? So you get exposure to like von Willebrand factor, and then you get all the platelets beginning to accumulate, creating a platelet plug. And then the very last thing that happens is going to be coagulation, and the ultimate goal is fibrin, right? And fibrin is what allows for the accumulation of all the red blood cells together. It also kind of shrinks a little bit, so you can try to protect the area that got damaged. Other thing, we're going to talk a little bit about platelets and thromboxane and how that can be affected by aspirin, which is a COX-1 inhibitor. We'll talk about that very briefly. Other things that are important are going to be like serotonin, calcium, things like that. But don't get too deep into the weeds on the things that are like completely necessary at this level for like platelets. But just know that those factors are going to come into play in the whole clotting cascade. So vascular phase, pretty quick, very rapid. And so you just get vasospasms happening to reduce the blood flow in that area. And then platelet aggregation is going to be one of the most important things, where you develop a platelet plug. And that's going to be mediated by things like von Willebrand factor. So let's watch a little video. Ah, dang it. There we go.
In a first step towards clot formation, platelets are recruited to the site of vessel injury by now exposed molecules of the vessel wall, such as collagen and von Willebrand factor. This factor mediates the linking of platelets to collagen via a specific receptor in the platelet membrane. The resulting change of shape of the platelet from its resting state into the dendritic form indicates activation. The activated platelet in turn releases prothrombotic molecules, such as adenosine diphosphate, ADP. By binding to its receptors, ADP induces aggregation. And recruits further platelets to the site. Thromboxane is another important mediator of platelet activation and aggregation. Under its influence, the platelets cross-link with each other. These interlocking mechanisms cause platelet activation to snowball. But grows rapidly. Activated platelets also trigger the coagulation cascade and thus the formation of thrombin. Thrombin, in turn, stimulates platelet activation even further, a continuous feedback loop. Additionally, thrombin induces the formation of fibrin to the mesh stabilizing the clot. The self-reinforcing process of platelet activation, crucial in the formation of blood clots, is an obvious therapeutic target in conditions caused by inappropriately triggered blood coagulation.
So, cool stuff. So this is one of the two main examples of a good positive feedback loop, right? The other one would be labor and delivery. So this is going to be one positive feedback loop, would be the whole platelet plug activation and accumulation. The more platelets you get to that site, the more platelets get attracted to that area. So it's a positive feedback loop. Labor and delivery, oxytocin, baby's head pushing against the cervix, causes more oxytocin, contractions, etc. So that's the other positive feedback loop. Side note. So platelets, temporary, right? It's just temporarily patching the area. You do get contraction, so that can help prevent further blood loss at that area. Thrombocytopoiesis, right? Platelets are going to be produced in the bone marrow, and they're going to be sloughed off from megakaryocytes. Right? You got these really giant cells. They're going to be hanging out in different places, and they're going to give off little tiny platelets. So that's where they come from. If you are not able to produce thrombocytes, that's thrombocytopenia, right? So that would, maybe you have a bone marrow disorder. Thrombocytosis, where you have too many platelets, could be a consequence of infection. CA is cancer, so you can get thrombocytosis, too many thrombocytes because of cancer and infection. So here's your megakaryocyte over here. All these little things that are getting sloughed off, those are all little platelets that are getting released into the blood vessels. So, all right. So let's talk about thromboxane real quick. That video talked about thromboxane and the role that it plays. So thromboxane is going to be pretty important for allowing the initiation of the whole platelet plug cascade. So thromboxane allows for attraction to more platelets. So you get more platelets in that area. So it creates a hypercoagulable state. The other thing that's also pretty important, but don't worry about this for this class, but glycoprotein is 2A and 3A, sorry, 2B, 3A. It's going to allow for platelets to be attracted to each other. But von Willebrand factor, that's definitely important because there's von Willebrand disease too. So that's going to be involving this specific factor. Now, why is this important, the whole thromboxane thing? Because when we take aspirin to thin out your blood, like you were mentioning, with as a potential therapeutic for sickle cell, which wouldn't be really effective, but it would be good for things like MI, patients with risk of stroke and things like that. You want to give the patient baby aspirin, right? So 81 milligram baby aspirin is a good option for those kinds of patients. And why is that? It's because aspirin is a COX-1 inhibitor. So COX-1 and 2, that's cyclooxygenase. And cyclooxygenase is really important for the production of prostaglandins. So that would be, for example, to mediate inflammation, fever, pain. That's why when you take ibuprofen, aspirin, it helps prevent pain, right? Because it's going to be blocking COX-2. So if you block COX-2, you can reduce pain. If you block COX-1, you're going to reduce prostaglandins, which can actually affect the gastric mucosa. That's why a person who takes NSAIDs a lot can start developing peptic ulcer disease, right? Because they're basically preventing the ability to produce gastric mucosa, or gastric mucus, which would protect the lining of your stomach. But therapeutically, if you were able to block thromboxane from being formed, then you can actually help prevent platelets from getting attracted to each other. That's the whole point of taking baby aspirin. So my dad, he's on baby aspirin now. He used to be on warfarin. They took him off warfarin because he was a bleed risk, and then he had a stroke a week later. So then they decided to put him back on an anticoagulant. So they put him on baby aspirin. So far, so good. He's doing a lot better. He's just on baby aspirin now. But baby aspirin, that's going to be a very commonly prescribed medication for older adults, right? Because older adults, higher risk factor of MI and stroke, especially if they have any sort of cardiac arrhythmia or long-standing hypertension. So von Willebrand factor, super important. If you have damage to the endothelial, von Willebrand factor gets exposed. Platelets now get attracted to that. Platelets then also produce von Willebrand factor, which can attract more platelets. So remember that GP thing I was talking about here? So your glycoprotein. The glycoprotein is also going to bind to the von Willebrand factor. So here's your glycoproteins on the platelets. You got von Willebrand factor attracting both of the glycoproteins from each of the adjacent platelets, and that's how you get that platelet plug cascade. Let me see if this is that same video.
It's called Adam TS13. Platelets coexist with many clotting factors. One is called von Willebrand factor. Catches the platelets, helping them to clot. Imagine tennis balls caught on strands of flypaper. To keep the platelets from clumping together too much, Adam TS13 cuts through the von Willebrand factor. Allows the platelets to continue. Inhibiting Adam TS13 causes dangerous blood clotting throughout the body, causes TT.
Yeah, don't worry about the whole Adam thing that she was talking about. Just kind of be familiar with what's going on with von Willebrand factor, because that's going to be important when we talk about von Willebrand disease, which is going to affect your platelets. It's going to affect your bleeding time. All right, so coagulation phase. This is where you start getting your clotting factors, right? And there's a bunch of different clotting factors. I only really want you to be familiar with a handful of them that are going to be pertinent to this class. But there's going to be 12 major clotting factors. These are produced by the liver. So if you were to have liver failure because you're a raging alcoholic or maybe you have hepatitis, what would happen? What would you start getting? You think you'd start bleeding more? Yeah, you might start seeing like petechia, purpura, things like that. You could see those manifestations on the skin. You can also get maybe like internal bleeds because of that. So if you're not producing clotting factors, you're not going to be able to produce blood clots, right? So you're going to start bleeding out. You get hemorrhaging. The two major pathways, extrinsic versus the intrinsic. Extrinsic, I want you to associate that with the actual tissue damage itself. So extrinsic, I don't know, maybe the way I like to think of it, maybe like my ex hates me, so she stabbed me. And so now my blood vessels are exposed to clotting factor 7. All right, so that's the extrinsic pathway. So it involves tissue damage, clotting factor 3, which is tissue factor, and then factor 7, which eventually winds into the common pathway of factor 10. Then the intrinsic, it's intrinsic because everything is sort of already there in the blood to allow this cascade to take place, but it does require collagen first. Collagen is going to be kind of the instigator for this. Then when you have collagen, then you have factor 12 is where you start with. You get factor 12, which eventually leads into factors 8 and 9. I definitely want you to remember factors 8 and 9 because of hemophilia. Hemophilia A is factor 8. Hemophilia B is factor 9. And then eventually that leads, again, into the common pathway. Once you get into the common pathway, factor 10 is going to activate prothrombin activator. Then that's going to turn into thrombin. That's why you get thrombosis. And then thrombin is going to convert fibrinogen into fibrin. And the fibrin is what's water insoluble, right? And it's going to create a nice little mesh, allowing all those red blood cells to agglutinate and congeal together to create a proper blood clot. Let's watch a little video on the clotting cascade.
At the site of vessel injury, the first platelets arrive to start sealing the wound. Simultaneously, the coagulation cascade with its various coagulation factors is activated. This involves two pathways, the extrinsic and the intrinsic pathway. Extrinsic activation begins with unexposed molecules of the vessel wall, such as tissue factor, which forms a complex with factor 7. Finally leading to the activation of factor 10. This factor 10A is the point at which the extrinsic and the intrinsic pathways of the coagulation cascade meet. The intrinsic pathway consists of various coagulation factors activating each other in a chain reaction. At its end, a complex with an additional cofactor is formed. This complex now activates factor 10. Since the two pathways merge at the level of factor 10A, this factor has a pivotal role in the coagulation cascade. Further down the cascade, factor 10A, in combination with 5A, activates thrombin and induces the so-called thrombin burst. One molecule of factor 10A catalyzes the formation of 1,000 molecules of thrombin. Large amounts of thrombin cause the further activation of platelets, the enhanced formation of fibrin. Fibrin then forms strands, making up the mesh that stabilizes the platelet plug within an arterial plug and holds together the red blood cells in a venous. It can be concluded that the central role of factor 10A in the coagulation cascade makes it a viable target for therapeutic intervention in pathologically altered blood coagulation.
Which we'll talk very briefly on that. So we're not really going to be, I'm not going to test you on the therapeutics like heparin, warfarin, Coumadin, all that stuff. Just know that different areas in the clotting cascade can be targets for different types of medications and drugs. I have a little slide that kind of talks about that very briefly. But here's one thing that kind of helps you think about it. Intrinsic pathway. Everything is kind of already there. So it's like within the circulation. Versus the extrinsic pathway, this requires exposure to the endothelial layers. So that's where you get tissue factor allowing that to take place. And then these are the major clotting factors that are important for you guys to be familiar with. So tissue factor, that would be associated with the extrinsic pathway. So that's tissue factor 3. Eventually that will help tissue factor 7 get initiated. And then the other important ones are 8 and 9, right, because of hemophilia A and hemophilia B. And then tissue factor 10 is going, or clotting factor 10 is going to be important for the common pathway. And 12, by the way, is that's intrinsic. So 12 needs exposure to collagen, and 12 gets activated, and then that allows for the intrinsic pathway to take place. Other things that are important, calcium and vitamin K are both going to be important regulators in the clotting cascade. In fact, factor 4 is calcium. And then some of these require vitamin K. So factor 2 requires vitamin K, 7 requires K, 9 requires K, 10 requires K. So these are going to be important to allow the clotting cascade to take place properly. And then no, when you hear tissue factor, that's factor 3. Okay, so factor 3 is tissue factor. And that's what gets exposed in the extrinsic pathway when you have rupture or damage to the endothelial layer of the blood vessel. So tissue factor 3, you get damage to the endothelial layer, some endothelial layer, then you get factor 7 getting initiated with factor 3, and this whole thing is going to be involving the extrinsic pathway. And here's something that we'll talk about later with disseminated intravascular coagulation, or DIC, also referred to as death is coming, because you often will die from that. You get basically a depletion of almost everything when you get DIC. So one thing that you can see is depletion of tissue factors. So you have coagulation, everything's happening, you're getting, all this stuff is getting used up, and then you get a depletion of all the clotting factors. Did I already play this? I've already played this. I think I did already play that. Okay, so we already went through all those different 12 clotting factors. So here's the whole cascade, right? So you have both the extrinsic and you have the intrinsic pathway. Extrinsic, you got stabbed maybe, and now you have exposure of tissue factor, or factor 3. And then that activates 7, and then you eventually get to the common pathway, which is involving 10. Then the intrinsic pathway, you get collagen exposure, which initiates 12. Then 12 gets activated. Then you get activation of factors 8 and 9, and then eventually factor 10. And then you have the whole thrombin, then fibrin being produced, and then you have the ultimate clot being produced as a consequence. So make sure you know factors 8 and 9 are associated with the 2 different types of hemophilia. There's also a third type of hemophilia, but we're not really going to go into in too much detail. But hemophilia A and B are the most important. And then here's a chart that summarizes all the things that are going on and what those fit into. So you have both the intrinsic and the extrinsic pathway. Let's start with extrinsic real quick here. So extrinsic, that's where you get stabbed. You get tissue factor being exposed. Eventually factor 10 is the common pathway. Then thrombin gets produced, fibrin gets produced, and you get the fibrin mesh, which is the ultimate goal of this whole cascade. On the other side, where you have the intrinsic pathway, that's going to be collagen, that's going to be triggering that to take place. Factors 8 and 9 are really important, and they're really important for this class because of hemophilia. So that's pretty critical. But then you have the common pathway, same thing. They both do the common pathway. And then here's kind of what your anticoagulants can do. So you have heparin, for example, can block the ability for thrombin to convert fibrinogen into fibrin. So that's one thing that heparin can do. So fun stuff. So here's another summary of all that. But these are including abnormal lab findings too. Oh yeah, by the way, with the extrinsic pathway, you have prothrombin time, so that's PT. And then on the intrinsic pathway, you have the partial thromboplastin time, so that's going to be PTT. So I'll give you an easy mnemonic for you to remember that in a second. So if you have blood vessel injury, and if you initiate the extrinsic pathway is going to be involving prothrombin time, as well as the INR. I'm not going to test you on the INR, but that's one way that you can measure, for example, if a patient's on warfarin or Coumadin, you want to monitor their INR levels. But don't worry about that for this class. And then if you have the intrinsic pathway being initiated, that's going to be involving partial thromboplastin time, so that's PTT. Platelets are going to be associated with bleeding time. Okay, so when you hear bleeding time, don't associate that with factors, tissue factors. Associate that with platelets specifically. So extrinsic prothrombin time, extrinsic partial thromboplastin time. Intrinsic pathway, you'll see hemophilia A and hemophilia B being involved in that, right? So intrinsic pathway is going to be involving factors 8 and 9. So here is the way that you can kind of maybe remember this. So Brad Pitt, right? You got those two T's. So PTT, so partial thromboplastin time, would be associated with the intrinsic pathway. So I is in Brad Pitt. So these are the important factors that play into that. Should also include factor 8 because 8 and 9 are associated with hemophilia, but don't worry about that, I guess. And then PET. So that's going to just involve PT. So that's prothrombin time. And then E for extrinsic. So this would involve exposure, right, after you're cut. So it would be tissue factor, factor 3, and then 7, and then the common pathway. Don't worry about this whole thing with like the liver being responsible for all that. That's just like, that's like kind of med school level stuff. So, and then vitamin K, don't worry about the different factors that are associated with vitamin K. Just know that vitamin K is an important vitamin to allow for this cascade to take place. All right, so damn, it's 12:43. So we got 2 minutes left. Let's go ahead and continue this. We'll start on this slide on Friday. Okay. Before we leave, anyone have any questions? All right, cool. We actually made it further than I thought we would, which is awesome. So that means that hopefully we can bang the rest of this out on Friday so we can leave next week's Wednesday for maybe like a big review session or something like that. So have a good day, guys. We'll see you all on Friday.